Thanks for joining us today, everyone. We're going to open up today with an opening statement from Health Minister Jim Ryder, followed by statements from Dr. Shahab and Scott Livingstone of the SHA. Minister Ryder.
Welcome, everyone. First of all, I'd like to thank the hardworking officials in the Saskatchewan Health Authority for their ongoing efforts to prepare and plan for the COVID-19 pandemic in Saskatchewan. As part of these ongoing efforts, SHA officials have prepared models and projections for the impact of COVID-19 on Saskatchewan residents. One model shows the impact of COVID-19 based on a 30% infection rate. As Dr. Shahab and other health officials have stated, if this were to occur over a very short period of time, it would overwhelm our health system. That's why every effort is being made to flatten the curve through social distancing and through self-isolation. This will spread the rate of infection over a longer period of time that our health system will be able to manage. It will also give our health system more time to better prepare for an influx of patients when it does occur. If these restrictions are not followed, our health system could be overwhelmed. However, if we all take it upon ourselves as our personal responsibility to abide by these restrictions, Saskatchewan will get through this without overwhelming our health system.
Dr. Shahab.
So I'll provide a quick update on the number of new cases. So as of today, we have 6 new confirmed cases, bringing our provincial total to 72 confirmed cases. 2 are 19 years of age and under. 59 are between the ages of 20 and 64. And 11 are 65 years and older. So you can note that at the moment, this is the demographics we expect, because most travelers would be between the ages of 20 and 64, but we obviously expect to see more 65 years and older as people who are south for the winter are coming back to Canada. 60% of the cases are males and 40% are females. Like the minister said, 5,757 COVID tests have been performed. I do want to emphasize that there was a bit of discussion yesterday about cases without a clear exposure history. So last week we were at 3 cases. We had eliminated 2 cases that they did have exposure history. We were down to 1. Today I can confirm that we have now 4 cases without a clear exposure history. 1 in the Regina area, 2 in the Saskatoon area, 1 in central Saskatchewan. So we have 4 cases without a clear exposure history. So like we discussed yesterday, this is an important inflection point in terms of these are the cases we were expecting, and now based on that, we will be making some further recommendations today about further increasing testing for people who have not traveled. We already test a large number of people in the ER, in the inpatient setting, in the long-term care setting, but we'll be expanding that to people in the outpatient setting who have not traveled. There is lab capacity to maintain that, and obviously we'll be looking at other measures beyond what are already in place to try to further limit or break the chains of transmission. And I just want to say a quick word of, I understand there was a modeling study that was released, which I have seen last week. There are going to be further iterations of that model. These modeling studies are similar to ones done by many countries and many other provinces. They project what will happen if the worst case scenario, where there's rapid transmission with no actions being taken at the public health level. But then they also project that if we do everything we need to do, both at the government level, but also at an individual and community level, how can we flatten the curve? So far, we have seen good evidence that we are maintaining, keeping the curve flat. But now with the initiation of community transmission, I think we really need to be even more diligent about doing everything we need to do in terms of staying home if you're sick. It doesn't matter if you've traveled, not traveled. You can get tested if you need to. And just keeping that physical distance, that social distance at all times. So maybe I'll stop there and hand over to
Mr. Livingstone.
Thanks. Before I start, I'd like to thank Dr. Shahab for all the work that he's been doing in his leadership through the COVID-19 work and collaboration with the Saskatchewan Health Authority. I'd like also to thank the physicians, healthcare workers, and other staff of the SHA for their professionalism, dedication, and hard work that's created this challenge of COVID-19 for us. I also like to thank the government delivering on the state of emergency and putting extensive restrictions in place for the population. These are critical measures, as you already know, and we certainly appreciate the government's decisiveness in taking them. This will help us bend the curve. I'd also like to acknowledge that I have someone with me on the phone from the organization to help answer questions, and that is Dr. Susan Shaw, our Chief Medical Officer. Over the last few months, the Saskatchewan Health Authority, together with the Ministry of Health, has been refining and updating our pandemic plan. What has occurred over the last couple of months is a shift from the hypothetical scenario to putting those pandemic plans in place. As part of that hypothetical approach to planning, as we're here today, you've seen some of the projections and the modeling that we're using to start our planning process. And today I'm here to provide you with information on how SHA is expanding its capacity to both meet the demand for future phases of COVID-19 pandemic, as well as deal with the situation overall to contain, delay, and mitigate this disease. Based on what we already know from jurisdictions across the globe, it is critical that we act immediately to expand acute care capacity here in the province of Saskatchewan to mitigate the impact of COVID-19. It's critical that people understand that we've got to consider some of the worst case scenarios when we're doing our planning. Any planning requires planning assumptions, and we needed to give our teams something to start that work so that we didn't get behind with respect to executing on how we were going to handle the cases coming to us within the pandemic. Modeling from other jurisdictions suggests the virus can affect up to 30% of the population and result in thousands of people requiring hospitalization. It's important to understand that the worst case modeling does not take into consideration the number of initiatives that have already been put in place to limit and lower the curve for us with respect to COVID-19. While we are updating this modeling on a regular basis, it's being fed directly to the teams across the SHA in the planning for response to COVID-19 for acute care and follow-up across the province. Northern, rural, and urban regions are all directly involved in the planning, and we will have the modeling as it continues to evolve specific to those areas of the province that it's required to properly plan our response. We know that demand will exceed capacity. All jurisdictions facing this challenge, we're not alone. This is the same. That's why we've already taken a number of actions to address the challenge. As you know, we've implemented a slowdown of non-essential services to increase our bed availability, preserve our supplies, and support a labor pool for reallocation across the province where they will be needed to care for COVID-19 patients. We've increased testing capacity and have expedited the process for confirming test results. We've created new and dedicated testing sites around the province. We're doing surveillance in hospitals, testing for COVID-19 in all declared outbreaks in long-term care homes. Our public health teams are leading aggressive contact tracing and are working to reduce spread. We've also drastically expanded the resources at our 811 by hundreds of employees, literally, that are taking calls from residents of the province, ensuring that they're receiving the right advice with respect to testing and self-isolation. These are just a few examples of the concrete actions that we've taken. Unfortunately, the pattern in other jurisdictions show that we need to do more. That's why we're announcing today the next phases of our COVID-19 response. We're taking action immediately to expand our acute care capacity so that we were prepared for as the situation escalates. This includes creation of dedicated spaces for COVID-19 patients within our facilities, creation of COVID-19 designated hospitals in Saskatoon and Regina and other areas of the province where they are required, and the creation of additional community-based acute care capacity, whether that's through the creation of field hospitals, in school gymnasiums, community centers, leased commercial space, or other spaces. These are the measures aimed at ensuring Saskatchewan residents get the care that they need from the right provider at the right time and in the right place. The reality is the only way we can avoid the worst case scenario is with help from the public. As Dr. Shahab has already said on many occasions, there isn't a health system in the world that can flatten the curve with the curve on the growth of COVID-19 without the help of the general public. Our ability to withstand capacity pressures as a health system will depend on you, the public. Practicing good hygiene, practicing social distancing, need healthcare providers to use our supplies effectively and efficiently when they're needed. We need people to avoid using our hospitals and long-term care facilities unless they are or visiting inside these facilities unless they're for compassionate reasons. We need to ensure that everyone in our lives is following the measures as best we can. We are supporting each other and we will contain this virus. Only together can we protect each other and minimize the severity of illness wherever possible and avoid the loss of life. Thank you.
Now time for questions. Arthur?
So, it was said in the general statement that we got from the SHA that this is an early draft based on an early model and that more data will be coming in the days to come. I was wondering if you yet know what that updated data says. Have you done further modeling to get a sense of what the cases, what the hospitalizations, what the death rate will look like, particularly following the new measures that the government has put into place?
So that's one of the challenges is so first of all, to answer your question, yes, we are continuing to upgrade the model as we get more data specific to what's happening in the Saskatchewan population and elsewhere with respect to the spread of COVID-19 globally. So that model is being updated regularly. We haven't got the next phase of that model in place yet and have provided that to the teams. But what you saw in the first sort of worst case scenario model is more of a provincial look. What we'll see in the next phases of our modeling is modeling specific to the areas of the province, Saskatoon, Regina, North and Rural, so that we can support the work of those teams to properly plan operationally what we're going to need to be putting in place. So I haven't seen the updated numbers yet. It's going to be something just like today and every day since we've seen this pandemic nationally and internationally it's a fluid process. We're seeing new information come to us daily. It's the same thing for the modeling, but we will this week have new updated models for those teams to plan.
You commit to making those models public as they become available so that the public can have a sense of what the SHA is expecting and what they should prepare for?
They're not a secret. Any planning occurs with planning assumptions, and these models are being used to direct our planning. So if it's releasing the models, I have no concerns with doing that. What I want to make sure that people understand is the models are just a planning tool. They're not going to be, what does that mean for my local community with respect to the services that we'll be accessing? The other thing I want to remind folks is as much work as we're doing around COVID-19, the Saskatchewan Health Authority is also responsible for continuing ongoing care of every resident of this province, regardless of whether they're inflicted with COVID-19, and that's part of our planning process as well. So this work feeds into our planning, but there's a whole pile of other things that we do that also need to be taken into consideration because we need to be able to deliver that care each and every day.
One more follow-up. The term worst case scenario appears nowhere in the document itself. And it makes, in some cases, what it calls a sorry, I have a bit of a stutter, makes some what it calls conservative assumptions, including a 30% contraction rate, which is lower than some experts have said we can expect. How is this a worst case scenario, given those circumstances?
Well, the balancing to your comment around it being a sort of the lower end of spectrum for infections is the fact that it didn't factor in all the impacts of the things that have been put in place in this province to lower and flatten the curve and minimize the spread of the disease, the social distancing, the closure of businesses. So I would say that all things being equal, we might have had a conservative estimate on the population, but that's also taken from the work around the globe of what's happening in each and every other location where we see COVID. So because the model will continue to be added to and be Saskatchewan specific and include data around what we see happening in the community with respect to community-based spread and the impacts of this. That's why I believe it's, we didn't have to tell our planning teams that it was the worst case scenario because they knew it was the first tranche at the modeling and they knew the modeling was going to continue to be refined, but we needed to give them a starting point.
Steph?
Why exponential growth in Saskatoon? Why was that part of the modeling?
The example in Saskatoon, you mean?
The document specifies that there's going to be an exponential growth of the virus, specifically in Saskatoon. Can you provide some explanation of that?
Sure. So again, in the document, Saskatoon was used as an example of what types of planning assumptions as well as operational opportunities we would have to deal with the disease in Saskatoon. It is not, Saskatoon is not going to be any different than any other community in this province unless the data shows us that it is. So that inside the slide deck, when you see, the concept of COVID-specific hospitals and the concept of field hospitals, that was a conceptual planning tool. What actually will result in Saskatoon for the plan is not what's on that page. It was to give an example. The other thing I want to reiterate is, though the deck has a Saskatoon example, the SHA plan is provincial. It doesn't just include Saskatoon and Regina. It's every resident of the province, every area of the province is covered by the plan.
I want to go back. Why use the 30% model when the federal health minister has said it's between 30 to 70% of people who could be infected? So why start so low, and given that that's the lower end of where we're looking at things?
I'm not an expert in the mathematical modeling around pandemics, and I'm not sure if Shahab has a question or an answer, or Susan, but I will say this, is that I'm not sure we've seen a 70% infection rate anywhere in the world. I'm not sure we've seen a 30% infection rate anywhere in the world, and I would suspect that that was one of the reasons, but I would...
Yeah. So I think there's new information emerging even now that suggests that if you let something grow out of control, how bad does it get before it levels off? And so far, no country has allowed that to happen. So but having said that, there are parts of the world, unfortunately, where there are significant resource constraints. So unfortunately, we will learn more from those settings. But of course, testing and reporting may not be that done in the same way. So that's one thing that we still don't know how it is going to behave in different parts of the world. The second thing is we already know from Southeast Asia that they had, even though it hit very hard in Wuhan and South Korea, initially the uptick of the curve was very significant. They actually flattened it very early through significant interventions. And that now they are looking at how do they sustain that? How do they come out of their extreme slowdown of non-essential work, other things? How do they come back to business after 4 to 8 weeks, 12 weeks, slowly, but while maintaining that flatness? And as we know in Hong Kong, they were going back to work, but then because a lot of people from Europe were coming to Hong Kong, they again saw importation of cases, but they're now trying to readjust their plan. So I think we're still, now still 10 weeks into the pandemic globally. We're looking very closely at Southeast Asia. What can we learn from there? Looking very closely at Europe because health systems and population demographics may be similar. And of course, looking very closely to the US. And finally, further to Scott's comment about, we are looking very closely with the modeling team. What are the intrinsic advantages of Saskatchewan? And that could be that we don't have large urban centers. We don't have the crowding that some large urban centers or cities have. So there may be advantages for us, but we need to maximize those advantages. We can't just take them for granted. We need to maximize them. And what are some of our inherent risks? So we've discussed in the past that rural, isolated, remote communities, they could be cocooned for a long time and not see any cases. But if they see cases, they would have to manage that in a very different way than a larger city. So again, those are all the planning assumptions that are being fed into the model again and again. But the model is a model, and we also actually work very closely with leaders at the community level, because they also then speak to what will work in their setting and what will be challenging, whether it's home isolation for a large number of people, whether it's social distancing, whether it's access to essential services. So I think those are discussions that are beyond the model. The model informs what actions need to be taken, but they need to be contextually relevant, urban, rural, remote. So that's a lot of the planning that goes around that's informed by the model, but not just predicated on the model.
And we have a comment from Dr. Shaw on the line.
No, I think Dr. Shahab explained it really well there.
Great.
I would just add this, just for some context. Dr. Shahab spoke about China. First of all, the officials doing this modeling, I want them to look at extreme situations. We need to plan for that and prepare for that. But for the context in China, as Dr. Shahab mentioned, there's a population 1.3, 1.4 billion, and deaths were about 3,300. You look at, a worst case scenario, we're looking at more deaths than that, but I think we need to to keep in mind some context on this. And again, it just speaks to how important the social distancing is, the self-isolation is, and all the restrictions we put in place.
And we have a question on the line. Operator, could you put through the next question?
We have Roberta Bell with Global Regina.
Hi, I just had a question regarding the creation of the field hospitals and the units dedicated to COVID-19 patients. You said that that's something you're working on now. Is there a timeline that you can provide us with for when, there might be those facilities opening, or if any of them are ready to do intake at this minute?
So the field hospitals don't exist at this point in time, and our focus, as I said before, is increasing capacity inside our existing systems, planning for what we are going to see over the next few weeks, as well as what we're going to see in the future. So we will, over the next couple of weeks, with the work of integrated teams across the province, flesh out these designs and know where we're going, if we're going to be lighting up field hospitals. But again, what's important to understand is the first phase of the acute care response, which doesn't mean there's not work going on in all other aspects of the phase, is increasing our capacity inside our existing facilities, ensuring that we're putting patients in cohorts of COVID if we're having those facilities share with other residents that are in there for other reasons that are not infected, so we need to protect them and keep them safe. And the changes that will be required in the healthcare system, which we've already started essentially, which impact all elective procedures, surgical and otherwise, are being done so not only to protect our capacity that exists today, but also to grow that capacity and be able to have the workforce to care for patients as they start coming in.
Is there a follow-up on the line? We'll go to the next question in the room, Murray.
I know you've done this before, but it seems particularly pertinent with throwing out hundreds of thousands of infected cases. Can you explain again why COVID-19 is so infectious compared to influenza, common flus and such, and more specifically, why, maybe putting in context, the measures being taken by the government, by yourselves, are combating that directly? Because I think people need to understand and not fear that large number because of doing things.
So if you'll bear with me, I'll start with SARS and MERS, and then go to influenza, and then come to COVID-19. So SARS, 2003, 10% fatality rate. So the fatality rate in the modeling would have been much, much higher than COVID-19. But SARS was less infectious than COVID-19. It was contained. It went around for 12 months. There were 8,000 cases, 800 deaths, 400 some cases in Canada, 40 deaths, but it was contained. It was put back in the box. Success story. 2012, MERS-CoV, even more lethal, 37% fatality rate. The modeling would have been out of the roof, but not very infectious at all, even less than SARS. It keeps spluttering up, transmits to a person who works with, camels, for example, and then transmits maybe to a household member, stops. It's been going around for 9 years, hasn't taken off. Several thousand cases over 9 years, but hasn't taken off. 2009 pandemic, we know influenza is hard to control. If COVID-19 was influenza, we would not be doing everything we're doing today. Influenza is very infectious, and it transmits through schools, to daycares. Mild cases are very infectious. Same principles apply. Touch is the main transmission plus droplet. But influenza, we don't try to do social distancing. As you know, when the pandemic came in 2009, our focus was antivirals, vaccine once available, some limited attempts to social distancing, the same things we do every year. If you're sick, don't go to school, that kind of stuff, but nothing to the scale we're doing with COVID, because we knew that, A, the mortality of influenza is lower. Even the pandemic strain in 2009 was 1 in 1,000, so 0.1%. And we knew that social distancing would not be that successful, and there are antivirals and a vaccine available. So all those reasons, and the pandemic was what it was. It was a bad flu season. So that was 2009. COVID-19 is somewhere in between SARS and influenza. Less infectious than influenza, but harder to control than SARS. If it had been SARS, China would have put it back in the box, but that didn't happen. Southeast countries, European countries, US, they've all now seen clusters. So, but, China, Southeast Asia have shown that you can substantially flatten the curve, and then that buys you time to get the health system ready. And then if you keep seeing, sporadic cases over a long period of time, over time, now there's data emerging that there is serology that suggests that there is some level of population immunity that starts emerging. So over time, the hope is that this will no longer become a novel coronavirus. Even if it doesn't go away, it will impact populations differently because there will be a level of herd immunity over time. But we want that herd immunity to come slowly. We don't want everyone to get infected, overwhelm the health system, which would cause significant pressures and challenges in providing care. We want that to come slowly. So sorry for that long answer, Maria.
Lisa?
The date in the first document, I guess, is March 19th or 20th, and you said that was kind of the first modeling. Isn't that a little late for first modeling for this? I think we already had cases, didn't we?
I can speak to that. Go ahead. So the models and the assumptions obviously were developed based on data from the first runs of the model. Actually, Canada had very few cases. We didn't have any significant cases, a handful. So we couldn't run the model on our cases. It was run on applying the assumptions of Wuhan, where there the epidemic started middle of November. They did not know something was going on till early January. So they had 7 weeks. They have 9 weeks of uncontrolled growth. So, but then when they realized that this is a novel infection, they found the virus, found the test, they then had to play catch up in a massive way. So that was the worst case scenario in terms of the modeling, that you pretend that you don't even know something is happening for 10 weeks, there's no test, or 11 weeks, and then they had, Chinese New Year, a lot of travel in and out, a lot of social events, without knowing that something was going on. So the worst case assumptions assumed a lot of things that have not now happened because we all know that it's coming, we're testing, so that is one thing. But then now, of course, we are inputting data from Europe because, we need to learn from what's different in Italy, France, Spain, UK, and there'll be inputting of data in Canada. And the modeling group in the UFS, working with the SHA and Ministry of Health, is excellent, but they're partnering with, colleagues throughout Canada because every geography is different. Some parts of the country have large, huge urban centers, so everyone's looking at their assumptions, but the input is actually initially from Wuhan, but then South Korea, Taiwan, Japan, and now increasingly, European countries. You have to input that data and see what did they do and how did that bend the curve or not bend the curve, because we don't have enough data to impute based on our data, but over time that we will be using that as well.
But you would have had data from China for quite a while, so couldn't that modeling have been done earlier? It just seems like last Friday.
So China's data, the study on 79,000 cases, and we can send you the link, that is released end of January. So their major data analysis which gave 79,000 cases in Wuhan, which gave hospitalization rates 20%, mortality rate around 2.5%. That study was released. I think I don't remember the exact date. It was, I think, mid-February, if I'm not mistaken, because it took them that long to actually start counting their cases. So that was the first cut that was put in. But then since that time, South Korea has had good data. South Korea had a very different transmission pattern. Wuhan, 9 weeks of explosive growth before you had a test. South Korea, seeding in large groups, so multiple seeding, rapid spread, but then rapid control. Hong Kong had sporadic seeding. Japan had sporadic seeding, lots of control, but they had the issue with the cruise ship. Lots of cases due to that, which doesn't count as Japanese cases. Italy was a surprise for Italy because they had seeding. They had high levels of community transmission without even realizing it. So it got ahead in Italy. No one's fault. It just happened that way. So, again, different countries had to deal with different starts of the epidemic, and we have to look at what's happening now, especially with our, 5 cases with no links. We think with no large events happening, both public and private also it counts. You can't have limits on gatherings in public spaces and have a house party. With limitations, with strong social distancing practices. And again, 20 people here with 2 meter separation, not touching eyes, nose, mouth is safe. 4 people standing together on the street corner, eating from a bag of popcorn and licking their fingers and taking some more popcorn, right now is absolutely not the thing to do. So, we have to change how we interact, and we have to maintain that, and then we have to see how does that impute into the model.
So the other thing I would like to add is the model is only one component of the planning, and building acute care capacity, we didn't need the model to do that, and we've done that already by over the last week with the reductions in services. We've already built capacity pending the influx of cases, which hasn't been occurring. So the model is important because it gives the team something to look at, and as it's more refined, as Dr. Shahab has said, it will be much more informative for our response. But where we are now is, with the model at hand, is we will over-respond if we only use the model as it exists without inputting any other components or successes with respect to some of the public-based initiatives that we've done. But the modeling is one component of the planning, and it's not that planning started last week. As I said before, we've been planning for weeks.
I believe we have a question on the phone line, operator.
We have Guy Quinville with CBC.
Yeah, thanks. I want to focus on respirators. The version of the model planning that we've seen has a page where it says Saskatoon, just for example, will need a capacity for 500 to 600 ventilators. Correct me if I'm wrong, but as of yesterday, the latest number we had is that we currently have 91 respirators for the whole province, but that more are on order. So my question is, that page outlined we need 500 and 600 alone in Saskatoon for the peak of this pandemic. And I know you've already talked about working with other provinces and even the Prime Minister on ensuring you can tap into supply at a time when every other country is in the same lineup as you are. So my question is, what are you doing right now to ensure, what are you continuing to do to ensure that when the peak hits any of our cities, whether it's Saskatoon or one of our smaller communities, that there will be enough ventilators for everybody who needs them?
Susan, do you want to take that question?
Yeah, I can talk to that. So it's Susan Shaw speaking in Saskatoon. I'm the Chief Medical Officer with the Saskatchewan Health Authority. So we have 91 adult ICU ventilators, we have 80 subacute ventilators, and then we have dozens of ventilators inside operating rooms all across the province. We also have a significant number on order that are, I think, on their way, and we can find out more about that with time. The challenge is the important thing is to slow and spread the curve, flatten the curve so that we don't get into what the slide deck shows, which is a worst case scenario. Over time, as the public measures work, and we will be ready.
Is there a follow-up on the line?
No, that's fine. Thank you.
Thanks. I go to Mark.
How close is the SHA to reaching the capacity for ICU and acute beds in the province?
Today? Yeah. So I can't speak to ICU specifically, but I can tell you that in overall acute care beds, and we haven't reached our lowest point yet because of the initiatives that were implemented last week, which are taking effect this week. But relative comparative, I mean, we've built, it's between 30 and 40% capacity within the system today, and compared to where we were, let's say, before Christmas. And we hope, well, not hope, we expect that to get better as this week goes on and we see the full benefits of not having all of the elective stuff going on. As well, I want to remind folks is that whenever we talk about capacity and have in the past, and there's some bed numbers in the deck that was that's out and about with the model, is we've focused a lot on Saskatoon and Regina capacity, which is always important because those are our largest tertiary center. But we do have capacity outside Saskatoon and Regina, and we will look. The planning for the province COVID response includes that all of our facilities that will participate. So we do have capacity now, significantly more capacity than we had last week, significantly more capacity than we had months ago. And that is really the first tip of the sword with respect to our response for acute care admissions. But as we've already said, and you guys have highlighted, it's not going to be enough. Even if it's not, the worst case scenario, and the data is wrong by a large percentage, we are still going to have to continue to build capacity, which likely will include expanding to field hospitals or other ways in which we care for patients in the province. And as Susan has pointed out, the most important thing is these numbers represent if the curve is not flattened, this is the capacity we're going to require. The more we flatten the curve, the more our capacity is not going to spike.
Are we doing enough to flatten the curve right now? Are the measures in place enough?
You know, the measures that have been put in place are as extreme. Oh, I've never seen anything like it. We were talking before in my entire 30-year career. We don't know right now, but we know from other jurisdictions when they have put in these measures, like, you know, other jurisdictions that have been more successful, perhaps South Korea, Taiwan, that they are bending the curve.
Lisa?
Dr. Shahab, in your introductory statement, you kind of mentioned that it seems like we're flattening things out a little bit, and it doesn't seem like we're getting the kind of exponential growth that other provinces are in new cases. Can you maybe talk to why that is?
So I think we have to remember that, you know, everyone wants to make a graph of cases over time. So we have to remember that imported cases are not really a growth within our population. They are imported cases. If you get 100 people coming in and there's 5 people who have COVID-19, that's 5 cases a day. If you have 1,000 people coming in, you'll see 50 cases a day. That as long as people who are coming make sure they stay home for 2 weeks, strict self-isolation, as we have said, no going shopping, no meeting friends and relatives. We already know there's going to be more cases coming in through importation because, you know, Canada has said if you are outside, come back. A lot of people are returning. We have to control that. So that those case numbers will keep rising, but all that is importation. If you see no secondary transmission related to that, that's one success. And we've seen a handful of household contacts due to imported cases. We've seen a handful of large events where there may or may not have been someone who traveled internationally. So that's one level of control, and that we have to keep doing for an indefinite period until, of course, there's no risk from anyone coming from outside. But then, in reality, our actual cases are now 4, which are the cases which are not imported that are, you know, emerging in our community. So that's really the start of a very new phase for us. And we're still investigating those 4. Maybe we'll find that someone met someone who had traveled. But, you know, if you don't find that in 3 or 4 days, chances are you're not going to find. So this is why we have to now watch that curve very carefully. And that in other parts of Canada has grown. Most new cases in other parts of Canada are due to community transmission. We want to keep that number as low as possible and as dispersed as possible, and not have ongoing chains of transmission. I think that's where the focus is going to be now.
And why haven't we seen that kind of community transmission? Is it because of the measures that?
I think personally, just like in the US, we have smaller populations. All of Canada has people coming back from overseas. We had less number of people coming. We did not have some of the events within Saskatchewan, like, you know, an outbreak in long-term care facility so far. So we've been, in some ways, fortunate that can happen in Saskatchewan. Hence, the cautions about don't visit, you know, someone in long-term care. Visit only for compassion reasons, with all precautions in place. You know, those are tough things to say for people who want to visit their loved ones. But, you know, that is really important right now. And so, you know, we have to sustain that for the next little while to absolutely minimize some of those clusters in populations that are most vulnerable. Healthcare environments, hospitals, long-term care.
We're going to take a question from the phone line. Operator?
We have Tori Gillis with CBC.
Hi there. We asked this question of officials for the province in Manitoba this morning. We're just looking at 2 provinces side by side with fairly comparable populations, and we're seeing more than 3 times as many cases now in Saskatchewan versus Manitoba. What can we attribute the difference there to?
So we're obviously looking very closely at BC, Alberta, Saskatchewan, Manitoba. It's hard to actually compare because I don't have the data of how many people are returning per capita in Manitoba versus Saskatchewan. But, you know, certainly Alberta, Manitoba, Saskatchewan some similarities, some differences. So I can't explain right now. It's a good question, but I don't have a good answer about why we are different from Manitoba and why we're so different from Alberta. But at the end of the day, we need to look at our data, what we have in place, and how do we keep refining that based on our local transmission. So I think we work collaboratively across the country. We have to work collaboratively across the prairies, but we also have to take actions that are based on our own data as well. So that's the best answer I can give at this point.
Is there a follow-up on the line?
Just to follow up, I just want to clarify as well, you've said at different points today 4 cases and 5 cases without a clear link. Can you just tell me which one that is?
So I apologize, 4 cases with evidence of community transmission as of today. Those numbers will keep going up and down because once you find a link, they go down. But over time, if we keep finding more new cases without a link, they will go up.
Arthur?
Just on those 4 cases, could you tell us where they're located, just so that people have a sense of where there is the greatest risk of community transmission? And further, given that one of them dates back to last week, how is it not time to acknowledge that we are almost certainly facing community transmission?
So we have to remember that the RO, the one person infects 1 or 2 additional people. So this is not like influenza. This is not like, there's a slow infection growth rate. We are looking very closely already in hospital settings, in long-term care settings. We're going to expand the testing in primary care settings. It's hard to predict, even if you're a community transmission, even if you are someone who got exposed to someone who had traveled. So the first assumption is the initial exposure to anyone is through importation, because but we have to start looking at how much we estimate the community transmission is, and we don't have any way to estimate that how many weeks back it would go, because obviously was someone just exposed to someone who had traveled and they just didn't realize that. So those are all assumptions, but over time, I think when you keep seeing cases popping up throughout different parts of Saskatchewan, that's one thing. The second thing is, we want to make sure that if you are a known case, either you're a return traveler or you're a close contact, you have to self-isolate to minimize those exposures happening on an ongoing basis. So I think right now, what my advice is that you have to act as if anywhere in Saskatchewan, as if there's unknown community transmission. That's not a reason to panic. It's a reason to be very thoughtful about day-to-day activities. You're going to buy your groceries, you're shopping, you bring your shopping home, you put your shopping wherever you need to put it, you wash your hands. You're not touching your eyes, nose, face while you're shopping, while you're out and about. You have to be very intentional about everything you do when you're out and about. And I think that is because these are just, these are based on, if you have a mild cough, you don't need to get tested. It may be evidence of community transmission, evidence of travel-related importation. But what we say is that as long as you maintain your social distance, you will not transmit to someone else.
But
so
I'm not sure that quite answers my question. Just where are they located? And given that it's now been days since you haven't been able to connect one of these cases to a source, why are you not openly declaring that there's community transmission?
No, so as of today, there's one case that is ongoing investigation for 10 days in the hope that we would find some connection. So that hasn't happened. That is in Regina. In Saskatoon, we have learned this morning that there's 2 instances where a link has not been found, and then one in central Saskatchewan. But we have to understand that most cases of COVID-19 will go undetected because they are very mild. They are a dry cough for 2 or 3 days, and they don't need to be tested either. What you have to do is practice social distancing all the time. Currently, you want to make sure that you only go to work if it's essential. Avoid crowding. Those steps will, interrupt chains of transmission, like, closing restaurants and bars. It's significant, but that is the whole purpose. And so we already went there without actually evidence of community transmission, but all those steps now will bolster our ability to interrupt chains of transmission. But it is as good as all of us. If I develop a dry cough and I come here and then I'm kind of touching all these surfaces and then everyone here is touching the surface and touching the eyes, nose, mouth, that's transmission happening. So we all need to play our role. I shouldn't be here if I have a cough. I should assume I have acquired COVID-19. If I just have a cough, no fever, I'll stay home for 2 weeks or as long as it takes. And that's what all of us have to do.
Just one follow-up, because that was really the same question. I know that you said that we're hoping that we can stretch this out so that we don't see the kinds of numbers that were in that planning document all at once. But the document says that even under conservative assumptions, the system will be overwhelmed. And I was wondering if you could explain whether you still feel that way, given the measures that have been taken, and whether you can be confident that everyone who needs a ventilator or needs an ICU bed will be able to get them.
Susan, do you want to take that one?
Well, we're talking about the theoretical and hypothetical, which makes it very hard. We are planning for all circumstances, and that's why that's one of the models. And the model that was shared today is one that is being used to consider, and it's being refined all the time. We're coordinating our efforts across the entire health authority to make the best use of the resources while ensuring that ongoing care for patients who need it without a COVID-related illness are able to access care.
Steph?
I would like someone to tell me when we're going to get those 250 ventilators. I understand they've been ordered, but when are we going to get them?
I'll give it a whirl. I would say every jurisdiction on the planet right now is trying to get ventilators. So, we're dealing with supplies with our normal suppliers. We're dealing with them with the federal government because they're trying to coordinate and do bulk purchasing. I'm optimistic we're going to get some. I don't know if it'll be full orders. And again, it's virtually impossible. I don't want to diminish the situation. Ventilators are a very big concern right now.
So just to be clear, we don't have any date or even a confirmation we're going to get all those 250 ventilators?
I don't know the exact status of confirmation, but certainly we can look at that. But I think it's fair to say, I'll just give you an example. We're having pretty regular FPT calls right now with the federal health minister. That exact issue has been brought up many times by many of the ministers across the country. It's a concern everywhere.
Minister, when did you brief on this document, or when did you first see it?
I don't know if I saw this specific one or not. Last week I'd gotten a number of, some short and one lengthy briefing on a number of different models. So I don't know that I saw this exact one, but I've seen versions of different models.
We're going to go to a question on the line here, operator.
We have Laura Woodward with CTV.
Hey there. I'm just wondering about testing capacity. Dr. Shahab mentioned earlier that he wanted to expand testing. What does that mean for people in Saskatchewan?
So that's a really great question, and we already know that BC and Alberta have changed their testing capacity. We are not there yet. At this point, our focus was till today, all returning travelers, stay at home. If you get fever or cough, talk to Healthline. If your symptoms are mild, you may be asked to just stay at home till your symptoms improve. If they are significant, you will be tested. Plus, of course, we were testing everyone in hospital with a severe respiratory illness where another cause was not found. And I have talked to clinicians who have actually tested hundreds of people, no positive, in the hospital setting, and these are people who have not traveled anywhere. So that's been the check on community transmission so far. Hundreds of tests have happened in the inpatient setting. Long-term care outbreaks are screened for COVID-19, and then very importantly, healthcare workers need to have access to tests, because if you're a healthcare worker and you develop a viral respiratory illness, before COVID-19, you would sit it out till your fever is gone, then go back to work. Now you are screened. If the test is negative, you still sit it out till your fever is gone, and then you go back to work. But if your test is positive, then you have to sit it out for another 10 days till your symptoms are gone, and your test is negative, or otherwise you're considered, able to go to work. So it's really important that that testing is conserved for healthcare workers, because we want to make sure that, healthcare workers are working if they're not sick, but not working if they have even mild symptoms. And also, there's been a lot of emphasis on not just personal protective equipment, because in the healthcare environment, again, just like everywhere else, the most important route of transmission is through hand, eye, mouth contact. So within healthcare workers, within patients, back and forth. So hand washing, hand hygiene, we've always stressed that. And when we had issues with antibiotic-resistant organisms, with influenza, COVID-19, the principles are exactly the same, but just that has to happen every time between every patient contact, plus, of course, appropriate, mask use where required. So I think, but the testing capacity currently is meeting all these needs. Obviously, it will expand now to testing anyone in the community setting where appropriate symptoms are present and worsening, not just cough. Cough, you stay at home. Most people are staying at home anyways now. But if you get a fever, you have underlying risk factors, you need to be seen anyway in primary care for worsening chronic lung disease, heart disease. You may be offered a COVID-19 test, and there'll be another check. We expect most of those tests to continue to be negative, just like all in the ER inpatient setting have been negative. But all those steps are there to watch very closely to see if you see an uptick.
Is there a follow-up on the line?
Yeah, there is a follow-up. I know you mentioned this a couple times, but I'm wondering, those 4 cases that you mentioned, are you saying there's no link to travel, or are you saying that they are for sure community transmitted?
So public health goes back again and again when there's a new case diagnosed and says, did you travel? No. Okay. Did you go to a large event? No. Did you have a close contact, went to someone's house who had recently come back in the last 2 weeks? No. So the answers, and then they go back again and again. Same questions. Have you thought of something? And if the answer keeps coming back, no, then you have to admit that, yes, this was an unknown exposure to someone who had traveled, maybe wasn't self-isolating, who knows. And that's, again, the point that at some point, we have to make sure that people who have traveled are self-isolating, people who have fever and cough, irrespective of being tested or not, are at home, and that is what will break the chain of transmission. But that is how we determined that this was most likely community transmission.
We have time for one last question. Murray?
Is there a better way for us to be reporting this in terms of ratios of cases? Because if I report there's 6 today and 14 yesterday, 10 a day, doesn't really mean much, particularly in the context of the modeling. Is there a ratio in terms of how many people may realistically be affected? I realize how difficult that is, because you have people coming in, you're starting to perhaps see community transfers, and certainly it's incredibly difficult because of all the moving parts. But is there a better way for us to explain how these numbers today relate to the overall document, where we're talking about the potential for 300,000 or whatever else it could possibly be eventually affected?
I'll take these comments back, and we'll try to display our data that explains if and when the trend is changing in terms of more of our cases now due to community transmission, in which age group demographic are they, what is our best guess of what the exposure could be. Because again, if you have lots of interaction with lots of people, your exposure is higher than if you have very little interaction with anyone. So you will try to tabulate that. We already are trying to get data on cases by age range. We already have said that till today, the vast majority of cases were either in people who had traveled or their household contacts, or in people who had gone to 2 events where there was a case. That large conference in Western Canada, where we had 3 cases in Saskatchewan, and an event in Alberta where we had 11 cases. So those were all the cases were explained, and now we have 4 cases where we don't have a significant link. But you're right, we'll try to have a table that gives this, but it is a changing, as new cases, it won't add up to all the new total cases. It'll add up to the cases where the investigation has been completed. So.
Thanks very much, everyone. That's all the time we have for today.
I have an important clarification. Okay. What do you mean when you say demand will exceed capacity? Are you saying that we're not going to have enough beds in the ICU and ventilators? Like, what do you actually mean when you say demand's going to exceed capacity?
Susan, do you want me to take that, or do you want to take it?
So
So I couldn't hear the question. The line's terrible.
I'm sorry, I just want to make, oh God. I just because it's been said a lot today and people are watching, what do you mean when you say demand is going to exceed capacity when it comes to responding to COVID-19?
Well, it means that the worst case scenario, if the public measures aren't followed and aren't as effective as we believe they could and should be, the transmission would result in cases that exceed the current capacity within the system, which means that we need to prepare and plan for that. So we're taking both, it's a multi-pronged strategy. The important thing is that the public does everything that we all can do to take care of ourselves and limit contact and limit the spread, while the healthcare system thinks long and hard about and does a lot of difficult work to prepare for the worst case scenario. And I'm hoping that that's not where we get to. It's really, again, my ask of all of you is to socially distance yourself, practice good hand hygiene, follow the travel isolation rules, and keep ourselves safe.
It seems that everyone is saying we hope it doesn't get there, but there's an inevitability that no matter what happens, demand is going to exceed capacity. So to Arthur's question, can you commit that people who need ventilators and ICU beds who are sick with COVID-19, can you commit that they will have those?
Our commitment is to prepare and do everything possible at our end to be ready. And our ask is that everybody out in the public keeps themselves safe.